So tumors of the kidney, benign tumors, malignant tumors. Name 2 benign tumors.
Oncocytoma.
Very good. Oncocytoma, most common benign tumor, oncocytoma. Most common benign tumor disease. Other is only 2. What is this?
Acute myeloid leukemia.
Angiomyolipoma. Okay. These are the 2 benign tumors. Malignant tumors is renal cell carcinoma. So we have again like stones. We have 4 types of stones, right? In the same way, we have 4 types of kidney tumors. In RCC, we have 4 pathological types of kidney tumors. So one is clear cell carcinoma. One is papillary carcinoma. One is medullary carcinoma. And the other is chromophobe carcinoma. Clear, papillary, medullary, chromophobe. These are the 4 various types of malignancies. 1 point for each. Clear cell carcinoma is the most common type. Like most common type of stone is calcium oxalate, C and C, clear cell here. Very important question. Why is it known as clear cell? Because suppose it's a cell, the cell is, the cytoplasm is almost clear. Okay, the clear cytoplasm. So they have a microscopic appearance of clear cell carcinoma. In patients who are associated in dialysis, in patients who are on dialysis, then the most common type of carcinoma is papillary carcinoma. Patients who are having sickle cell disease, they have medullary cell carcinoma, sickle cell disease, medullary cell carcinoma. And out of all this, the best prognosis is chromophobe carcinoma. Best prognosis is chromophobe carcinoma. So these are the 4 main type of malignancies: clear cell, papillary cell, medullary cell, chromophobe cell. Clear cell, most common type; papillary, most common seen in dialysis; medullary, most common associated with sickle cell disease; chromophobe, it is the most best prognosis. It has the best prognosis. Clear with this slide?
Yes, sir.
So here, genetic predominance. The one thing which you have to remember is genetic predominance and chromosome number 3. Most of the renal malignancies are associated with chromosome number 3. Okay, it has a VHL gene. What is this VHL gene? Von Hippel-Lindau gene. Okay, this Von Hippel-Lindau gene abnormalities are seen in renal cell carcinoma patients. Just remember chromosome 3 VHL. So what are the symptoms? Tell me the symptoms.
Pain, hematuria,
Okay.
loss of weight,
Okay.
clank mass.
Clank mass. Okay. Most important symptom, one thing you are not telling. Pain is okay.
Hematuria.
Yeah, mass is okay. Hematuria is okay. Loss of weight, loss of appetite is okay. These 3 things, pain, mass, and hematuria, it is a triad. What is this triad known as? Late triad. Because if these 3 features are there, the disease has almost progressed. So pain, mass, and hematuria. This is late triad. This is present only in 10% of the patients, and this is very late in presentation. Okay, either the patient will have pain, either the patient will have mass, either the patient will have hematuria. Okay, and peculiar thing to this is the patient will have something known as extra-renal manifestations. Extra-renal manifestations. So in this RCC, the patient will have extra-renal manifestations. That is some other things like hypercalcemia, hypocalcemia. Like this, so many other electrolyte imbalances, fever, like these symptoms will be there because of extra-renal manifestations of this tumor. They are not related to tumor, but the patient will have these type of symptoms. Out of this, the most common, can anybody tell me what is the most common extra-renal manifestation? If you have read, you can tell this. most common extrarenal manifestation of renal cell carcinoma. Raised ESR. ESR will be raised. See, the patient has renal cell carcinoma. There is no why the ESR will change? No correlation between that. But RCC patients still present with these type of symptoms. Those are known as extrarenal manifestations. Okay, some immune system alteration will be there. Hence, this will be present. The most common is raised ESR. The patient will have hypercalcemia, hypocalcemia, anemia, thrombocytopenia, leukocytosis, polycythemia. So many varied symptoms will be there. Out of this, there is a thing called Stoffer's syndrome. Heard about this syndrome before? Stoffer's syndrome? Yes, no?
Yes, sir.
No?
It's non-metastatic hepatic dysfunction.
Yeah, non-metastatic hepatic. Very good. Stoffer's syndrome is non-metastatic hepatic dysfunction. Okay. So, if by metastasis, if it gets dysfunction, it's different. Here, there is no metastasis, but the kidney will get dysfunction. Okay. Clear? These are the symptoms. Then we move on to the diagnosis. Here also the investigation of choice is CT, CECT. Okay? Yes, no? Come on, please answer. Yes, no, or want a break, lunch?
Yes, sir.
Is it stalker or stopper?
Stoffers. I'll write just 1 minute. Stoffers. Stoffers syndrome. STAUFFERS. Stoffers. It is non-metastatic hepatic dysfunction. The most common symptom, most common extrarenal manifestation is
Increased ESR.
increased ESR. Very good. Shall we break or shall I continue?
You can continue, sir.
Sorry?
You can continue, sir.
We can continue. Okay. Then we'll complete this RCC and then break for lunch. Okay?
Yes, okay, sir.
Yeah. So, renal cell cancer, this has a peculiarity. This is the only cancer which will metastasize into the renal vein, into the IVC. Okay. So, the malignancy can spread into the renal vein and IVC. Clear? So, the investigation of choice is CT, CECT. But MRI is the most accurate. It is to detect the tumor thrombus. If the question, see carefully, look at the question carefully, whether they are asking RCC or tumor thrombus of RCC. If they're asking investigation of choice of RCC, go for CECT. If they're asking investigation of choice for tumor thrombus of RCC, then go for MRI. Clear? Clear? Not clear?
Yes, sir.
Yeah. And here, see in this inferior venocavogram, it is not done nowadays. Inferior venocavogram is just put a needle inside the inferior vena cava, give contrast. This is the most accurate investigation for thrombus. But because of this high mortality, when you put a needle in the IVC, there is very invasive in it is. It is not normal. It is not minimal invasive. It is very invasive. So this investigation is not being done nowadays. But it is most accurate. It is not done nowadays. Inferior venocavogram. Am I clear here?
Yes,
Yeah,
sir.
I'm repeating one more time. Investigation of choice for renal cell cancer is CECT. 1. Investigation of choice for thrombus of CECT, thrombus of renal cell carcinoma is MRI. But inferior venocavogram, if it is there in the option, this is standard. This is the best investigation. But because of the high risk of complications involved, inferior vena cava you have to open, you have to put a needle, give contrast, insulate it. So it is not being done nowadays. But in the option, if it is there, 99% won't be there. But if suppose if they give you inferior vena cavogram, then it is the treatment, it is the investigation of choice for tumor thrombus. Okay. Yes.
Yes, sir.
Okay. So then FNAC. So okay, tumor is there. Tumor is there in the kidney. Then what you will do next? RCC is there. What you will do?
Staging.
Sorry.
Staging.
Staging.
Staging. Okay, CT is done. CT is done. RC is there only in the kidney. It is not went anywhere. So next. What next?
Surgery.
Direct surgery or something in between.
Biopsy.
Will you take a biopsy or not?
Yes, biopsy. Biopsy.
No need. No need. In kidney, there is no need. In all the other organs, you are correct. Don't confuse, please. In all the other organs, you are not supposed to take it out unless you are proven that biopsy. What is biopsy? It is nothing but a small sample. Unless proven, you have to not. You have no right to remove an organ. In all other organs, even in colon, even if it is esophagus, wherever it is, breast, thyroid, soft tissue, wherever it is, except for kidney. In kidney, investigation is 100% accurate. It is 95% accurate. Okay, so there is no need to go for biopsy in kidney. If it is CT, if it is showing malignancy, it is malignant. That's all. Okay.
Okay, sir.
Yeah. But only indications for FNAC is MLA. Once you're suspecting metastasis, there is lymphoma. You're suspecting lymphoma. You're suspecting an abscess. In these three conditions only, you will take an FNAC from the kidney. Otherwise, FNAC no role. MLA, metastasis, lymphoma, abscess. You can write these codes in one page so that before going to the exam, single day you can revise it. Okay. Metastasis, lymphoma, abscess. These are not done. FNAC is done only in these conditions. Okay. Now, treatment. Management of RCC less than 4 centimeters. Did you see this question anytime before?
Partial nephrectomy.
Yeah, partial nephrectomy. Very good. So, what is the staging of the kidney? Stage 1, stage 2, stage 3, stage 4. Stage 1, less than 7 centimeters tuber. Stage 2, more than 7 centimeters but within the gyrotous fascia. Stage 3, outside the gyrotous fascia. Outside the gyrotous fascia into the veins. Stage 4 is extensive spread. Okay, these are the 4, less than 7, more than 7, gyrotous, into the veins, extensive spread. So see here, stage 1, the tumor is less than 7 centimeters. Stage 2, tumor is more than 7 centimeters. Stage 3, it is invading into the veins. Stage 4, outside the gyrotous fascia into the major veins. Okay, so these are the 4 stages. No need to remember these stages, but for this one, stage 1, if the tumor is less than 7 centimeters, you can do partial nephrectomy. That is, if the kidney is like this, tumor is like this, you will remove only this part of the kidney. This is known as partial nephrectomy. The other name for this surgery is can anybody tell me? You are saving something here. What you are saving? Half of the kidney you removed, half of the kidney is left. What are you saving? NSS. Other name of this NSS. Nephron. Nephron sparing surgery. You are sorry. So you are saving some nephrons here. You are not removing the whole of the kidney. So it is a nephron sparing surgery. Nephron sparing surgery. Remember. Okay. Nephron sparing surgery. Stage 1, it is partial nephrectomy. For stage 2, it is radical nephrectomy, removing the complete kidney. Okay, stage 1 it is partial nephrectomy, stage 2 it is complete nephrectomy. So what are the other indications for partial nephrectomy? So remember this mnemonic BOSS, stage 1, one stage. Bilateral, if the patient is having bilateral, here one tumor, here one tumor. If you remove whole of the kidney, what will happen? Both kidneys, what will happen? Think logically.
The patient cannot.
The patient will be on dialysis. The patient will be on dialysis, right? So in these conditions, you have to do partial nephrectomy here and partial nephrectomy here. So in bilateral disease, you have to do. In stage 1 tumors, you have to do. In RCC with syndromes. RCC with syndromes. Why? In syndromes, you have to do partial nephrectomy only. Think logically. Just think and tell me, you can answer. See, this is the patient with chromosome 3 abnormality. Von Hippel-Lindau disease is there for him. Chromosome abnormality is there. He had a tumor now. If you remove this kidney, there is high chance that he may develop the kidney a tumor here also next. So because he is having tumor, there is chance of recurrence. So you have to only remove this part of the kidney. Next time if it comes here, you can remove this part. Okay, but you should not remove the entire kidney in these patients, in VHL patients. Clear? Yes, no?
Yes, sir.
Yes, sir.
Yeah, in solitary kidney, if the patient is having only single kidney, in which patients only single kidney is same? Congenital abnormality, I told you.
Horseshoe.
No. Horseshoe is okay, but any other better one thing I told you. Renal,
Agenesis.
agenesis, unilateral renal agenesis. The patient is born only with single kidney. He has only a single tumor. If you remove that, he will be going into permanent dialysis. So you have to remove partial nephrectomy. You have to do only partial nephrectomy. So you remember, boss, it is bilateral disease, stage 1 disease, syndrome disease, solitary disease, solitary kidney. In these 4 conditions, you have to go for partial nephrectomy. Remember this, very important MCQ. And what is the other name for partial nephrectomy?
Nephron sparing.
NSS.
Nephron sparing surgery. Very good. So in management of RCC less than 4 centimeters, if the RCC is less than 4 centimeters, radical nephrectomy in stage 2, partial nephrectomy stage 1, chemotherapy. For metastatic, it is chemotherapy. Surgery following for metastasis. Following chemotherapy is for metastatic. Both. Anything you can do. These are the chemotherapy agents. Sunitinib. This is the chemotherapy agent for RCC. Sunitinib. And nowadays, these drugs are coming up. Ipilimumab and nivolumab. These are immune checkpoint inhibitors. What are these? Immune checkpoint inhibitors. What are these drugs? Which group? Monoclonal antibodies. Very good. So remember these 3 things: sunitinib, ipilimumab, nivolumab. Okay, this completes RCC. So what is the most common type of RCC?
Clear cell carcinoma.
Okay,
Onyx.
clear cell carcinoma. Which has the best prognosis?
Chromophobe.
Oh,
Chromophobe. Others also, I can hear 3 answers out of 30. Others also, is it clear?
Yes, sir.
Please, any doubts in this? We'll discuss again. What is partial nephrectomy? What is radical nephrectomy? What are the stages of kidney disease? What is the triad? What are the external manifestations? Everything you have to know. Okay?
so can we summarize RCC just 1 second before break?
Okay.
Just to summarize.
Okay. Shall I summarize or anybody will volunteer?
Can I, sir?
Yeah.
RCC can be divided into malignant and benign. Benign, most common, is on oncocytoma.
Sorry.
And
Not RCC. Renal tumors are divided into 2 things. Renal tumors, either malignant or benign.
Okay.
In malignant, RCC is the malignant tumor of the kidney. Okay. Next.
So yeah, clear cell is the malignant one, which is most common.
Yeah.
And the papillary type of malignant tumor is mostly seen in dialysis patients, which is the most common among them, and medullary type in sickle cell disease patients, and chromophobe, which has the best diagnosis.
Okay. Best prognosis. Okay.
Best prognosis. And genetic predominance and chromosome number 3 and VHL gene involvement is seen in malignant
Okay.
tumors. And symptoms mostly late triad, which indicates the late stage of the cancer,
Okay.
pain, hematuria, and mass, and loss of weight, etc. Extrarenal manifestations are also seen, which can include electrolyte imbalance, fever, anemia, leukocytosis, polycythemia, etc. The most common extrarenal manifestation is increase in ESR
Okay.
and Stopper syndrome.
Yeah.
Diagnosis can be done with investigation of choice as CECT, which is 95%
Okay.
for RCC, and when the for metastatic type, which is tumor thrombus of RCC, we will go for MRI.
Yeah.
And FNAC is not done, not needed for renal cell tumors,
Yes. Okay.
but it's needed for other conditions. So
Yeah.
the only indication for FNAC is MLA, which is metastasis, lymphoma, and abscess.
Very good. Yeah.
Management of renal cell carcinoma for tumors less than 7 centimeters for stage 1, which is partial nephrectomy, aka nephron sparing surgery. The
Yes.
indication for nephron sparing surgery, aka partial nephrectomy, is PAUSE, bilateral synchromatous RCC, which is bilaterally present, and stage 1 tumors. Then syndrome associated,
Yes.
example like VHL gene involvement, and
Yes.
solitary kidneys. Solitary kidneys seen in ANF. What is that, sir?
Unilateral renal agenesis.
Unilateral renal agenesis.
Yes.
And the management can be less than 4 centimeter and nephrectomy and all, and then sunitinib and ipilimumab and nivolumab. These are the drugs, and others can be of surgical intervention.
Okay. Good.
Thank you.
Yeah. Okay. So Wilms tumor. We completed malignancies part in the morning. So pediatric malignancies, pediatric renal malignancies. Okay. See here. See. Look at the question carefully before you answer these questions, because most common pediatric renal malignancy. If word renal is given, then it is Wilms tumor. Most common pediatric abdominal malignancy. It's not Wilms. What is this? Other name for Wilms tumor is nephroblastoma. Nephroblastoma. Nephro. Kidney. Nephroblastoma. Okay. Other name, most common pediatric abdominal malignancy. See here, most common pediatric, not renal. It is abdominal. Abdominal malignancy. What is this? It is nephro.
Blastoma.
Neuroblastoma. Very good. It is neuroblastoma. Okay. Difference. Small difference is there. See. Neuroblastoma, nephroblastoma. How to differentiate these two? Simple. Nephroblastoma is unilateral, whereas neuroblastoma, it will cross the midline. That is one difference. And in neuroblastoma, there will be intratumoral calcification. 2 points. One is it will cross the midline, and there will be intratumoral calcification in abdominal malignancy, in neuroblastoma. And see this question, they'll ask this also. Second most common pediatric abdominal malignancy. First is neuroblastoma. Second most common is
Williams tumor.
it is nephroblastoma, Wilms tumor. Again, it is Wilms tumor. Okay. So don't confuse. Most common renal, most common abdominal, second most common abdominal. Okay. Now I'm just deviate. Which is the most common tumor in childhood? Oncology, a small bit of oncology. Which is most common tumor in childhood?
Is it retinoblastoma?
Most common tumor. Okay. Most common malignancy in childhood. Sorry, my question framing is wrong. Most common malignancy in childhood.
Leukemia.
Leukemia. Yeah, very good. See, here also there is a lot of confusion. Most common malignancy, if they ask in the question in children, not in our surgery, but wherever, most common malignancy, pediatrics or somewhere, it is leukemia. Blood cancer is the most common malignancy in children. Whereas most common solid tumor, if they ask you in the question, solid tumor, leukemia is blood cell tumor, right? So solid tumor, if they ask, then it is brain tumor. Brain tumors are most common in childhood. Okay, so most common malignancy is leukemia. Most common solid tumor is brain tumors. Okay, make these points clear. These are like repeated even from the time I am writing, like almost since 10-15 years. These questions are every time they'll ask the same question. Okay, then so what is this Wilms tumor? Why we call it as nephroblastoma? See, because the kidney, it arises from the small point regarding its origin. It arises from metanephric bud. Metanephric bud. This is the origin. So, if this is the abdomen, kidney originates in the right iliac fossa, so in the iliac fossa, and it ascends up, and it ascends the normal loin position. It ascends up. Can you name an organ which will start up and it will gradually come down and settle down?
Testis.
Very good. This is exactly the opposite. In kidney, the origin will be in the iliac fossa. It will gradually ascend up. Okay. So this Wilms tumor, it will start in infancy only. See, normally the kidney will have three components: blastomal components, epithelial components, stromal components. Blaster, you remember it as BEST: blastema, epithelium, stroma. What happens is once after the kidney grows in size and attains its normal location, this blastomal component will disappear. There will be only epithelium and stroma. This blastema will disappear. But in Wilms tumor, what happens is all these three will proliferate. What is tumor? Tumor is nothing but proliferation, unwanted proliferation. Wanted proliferation is normal tissue. Unwanted proliferation is tumor. So when these three elements together they proliferate, then it is known as Wilms tumor. If there is a blastomal component, then it is a Wilms tumor. Okay. So see here, they arise from the kidney composed of three elements: blastema, epithelium, and stroma. This is primitive kidney, not the normal kidney, primitive kidney. That is in the neonates. Okay. So how it will present? Most common, it is abdominal mass. While bathing and all, the mother will notice it. Most often the mother will notice a abdominal tumor, asymptomatic abdominal mass. Okay. And here also there is a triad characteristic of mass, fever, and hematuria. Same like late triad, but here it is microscopic hematuria. There will not be any gross hematuria, because see what happens is the collecting system is normal most of the times. Suppose this is the kidney, this is the collecting system. Only the tumor is exophyte most of the times. So collecting system is not involved. So microscopic hematuria only is seen. Okay. And diagnosis: ultrasound is the first investigation, CT for staging. No investigation of choice here, but just ultrasound and CT. And which is superior to differentiate between neuroblastoma and nephroblastoma is MRI. MRI is the gold standard to differentiate between these two. Okay. Always remember, first investigation and best investigation are not the same. First investigation is it should be available to everyone. See, suppose a patient suppose his headquarters is Chennai and he is situated 200 kilometers away from Chennai, some interior place. Ultrasound is available at every place now. Okay. So this is the first investigation, which can be done at any place and which can be done with ease also. There is no much equipment cost or single radiologist can do. But if you want to do a CT, you have to have a CT scan room, which is costlier affair, and it is not available in all new corners. Okay. So that is the best investigation, and first investigation will be ultrasound every time in kidney. Okay. So surgery. There is no partial nephrectomy here. Surgical excision, that is radical nephrectomy. It is the treatment of choice. Okay. So here, if you go little into the next level, is it okay? Your understanding, right?
Yes, sir.
Yeah. Here there are two schools of thought. One is European group. one is American group. See the thinking, how it differs between these two. What European people, they'll tell is, first do surgery, then give chemotherapy, radiotherapy. Americans, they tell first to give chemotherapy, radiotherapy, then do surgery. They are protocols. Okay, 2 protocols have been developed for Wilms tumor. We don't have our Indian protocol. We either follow a West or East protocol, European protocol or American protocol. In this protocol, what is nothing complicated, just simple. First of all, there is a tumor. A child comes to us with Wilms tumor. Whether to operate first, give chemotherapy, radiotherapy is one question, or give chemotherapy, radiotherapy, and what will happen if you give chemotherapy and radiotherapy to the tumor? Initially, it will
regress.
It will
Regress.
regress. Yeah, better term in oncology we use downstaging. It will downstage the tumor. Stage will be down. See, suppose the patient is having 3rd stage or 4th stage. If you give chemo and radio, the patient will come into 2 or 1, which will be easier for surgery also. There are pros and cons for both of them. No need to go into the details, but just remember there are 2 protocols, 2 schools of thought in treatment of Wilms tumor. But for us, the treatment for a surgeon, for a urologist, the treatment of choice is radical nephrectomy. That's it. Okay. And here also, see, if the patient is having a solitary kidney, if there are bilateral renal tumors, if the tumor is in horseshoe kidney, or if the tumor is thrombosis IVC above the level of hepatic veins, respiratory distress is there due to metastatic disease. In these conditions, we have to give preoperative chemotherapy and radiotherapy. Preoperative CT and RT. Chemotherapy, what is CT? What is RT? What is chemotherapy? What is radiotherapy?
Drugs or chemotherapy?
Yeah, drug therapy. Chemotherapy is nothing but chemotherapeutic agents. Giving chemotherapy. What is radiation therapy?
Radiations are provided.
Okay. So this is one important MCQ. In these conditions, we have to give preoperative treatment. Before operation, we have to give this treatment. What is the other name of this treatment? If you give before surgery.
Neoadjuvant.
Very good. It is known as neoadjuvant therapy. Neoadjuvant chemo or neoadjuvant radiotherapy. Very good. Okay. Then prognosis. The histology of Wilms tumor and the tumor stage is identified as the most important determinant of prognosis. So the histology is important. See, these type of questions will come you. What is the most important determinant of breast cancer, which will determine the prognosis? That is how many years he will live. Prognosis. Okay. For breast cancer, what is that? Which will tell you the prognosis? Can anybody tell me? For breast cancer?
Axillary lymph node.
Very good. Axillary lymph node for breast cancer. The same, only 3 I will tell you, rest remember. For breast cancer, it is the status of the axillary lymph node. If the axillary lymph nodes are involved, prognosis is bad. If the axillary lymph node is not involved, prognosis is good. Simple. Whereas in Wilms tumor, the histology of the Wilms tumor is important. That is histology. How bad is the disease on microscope? Okay. That is how many blastomal components are there. I told you in the first only. Blastomal components is a primitive component. So if blastoma is more, the histology is poor. If blastoma is less, normal components are there, the histology is good. The histology of Wilms tumor, it is the important determinant of prognosis. That is one. And for sarcoma is not in this. I am slightly deviating. These 3 are important MCQs. For sarcoma, what is the most common prognosis? Anybody? Histology over, lymph node status over, anything? Sarcoma. Just guess and tell me, no problem. For sarcoma, grade is the important finding. Grade. On histology, you see the grade of the tumor. Okay. These are the 3 things. Breast cancer, just repeat. Breast cancer, most important factor for prognosis. Determinant of factor for prognosis. Breast cancer.
Axillary lymph node.
For Wilms tumor.
Blastoma. Histology.
Histology of the Wilms tumor. Then for Sarcoma. Sarcoma,
Stage
it is a grade of the tumor. But recently, in one exam, what happened is they did not give histology. That's why I purposefully wrote this line. In one exam, they did not give the histology. If histology is not given as an option, then stage is the second important point. Stage, tumor stage. Okay. Remember, histology is the thing. But in that options, 4 options, histology is not given. They gave stage, grade, some other 2 things. So stage is important. If histology is not there. Okay. Just remember it once. Okay, these are some pediatric tumors which are discussed. Most common solid tumor is brain tumor. Most common cancer is leukemia. Most common malignant tumor. Most common extracranial solid tumor. Most common abdominal malignancy, neuroblastoma. See this point? Most common extracranial solid tumor. If you add one thing, the answer will change. If you remove one thing, the answer will change. What is the most common solid tumor of childhood?
Brain tumor.
Brain tumor. They just added extracranial. Most common extracranial is again our neuroblastoma. Okay, and see here, most common prime. These are all important. Just this is not for completion or anything. These are important. Okay, sometimes these questions they'll ask you, not regularly, but sometimes just like that. It is just one word. If you know, you'll answer. That's it. Okay, so most common primary malignant renal tumor of childhood, Wilms tumor, no doubt about it. But here, see here, most common renal tumor of infancy. It is only in less than 1 year, and it is not there. They're not asking malignancy. Okay, they're just asking renal tumor. It is congenital mesoblastic nephroma. Congenital mesoblastic nephroma. It is most common renal tumor of infancy. The question will be same. Most common renal tumor of infancy is congenital mesoblastic nephroma. Most common soft tissue is not necessary, just for completion. So you got this clearly, right? What is neuroblastoma? What is nephroblastoma? What is brain tumor, leukemia? What is Wilms tumor? What is congenital mesoblastic nephroma? Okay, clear? Clear? Not clear? Okay. So this slide you can just after, not for now, but these are very important science of urology. So out of this, you know this Golfol ureter. Where is this seen? Golfol ureter. Golfol.
Bladder.
GUTB.
Very good. TB bladder. Thimble bladder. You know this also. Thimble bladder. Thimble bladder. Where is it seen? Thimble bladder.
in bladder.
Sorry.
GUTB.
GUTB, right?
Yeah,
Okay.
GUTB. Same. GUTB. Okay. So the others also, I will show you the images, but for time being, rim sign or crescent sign, hydronephrosis, spider leg, polycystic kidney, flower vase appearance, horseshoe kidney, drooping lily, duplex moiety, cobra adder head, ureterocele, sandy patches, schistosomiasis. So I'll show you all the images, don't worry, but for sandy patches, see the bladder. If the bladder is there, there will be small sandy patches. Okay, so that is schistosomiasis. Recently, not in FMG, but they asked this question like so much history was there. A 30-year-old African origin came to India and settled in Delhi. He had hematuria. All the investigations were done negative. Cystoscopy was done. It was showing sandy patches. What is the diagnosis? So no need to read the entire question. Just sandy patches is there. So you just with sandy patches it is schistosomiasis. What is the other name of schistosomiasis? Microbiology knowledge. Other name of schistosomiasis.
Bladder carcinoma.
No, schistosomiasis. It starts with B. Somebody? Bilharziasis. Bilharziasis. Okay.
So can you spell it?
Yeah, I'll write it.
Yeah.
Okay, even if the option is bilharziasis or schistosomiasis, so I am concerned only with one word. What is that? What is that?
Sandy patch.
Sandy patch. Yes. If sandy patch is there, then the answer is this thing. Okay, it's very important. So this completes the tumor part also. Stones part, infections, tumors are complete.